but we shouldn't. So I will be recording this event at this time.
Okay, so do we, I think when we want to record, we need to get everybody's permission to say, if anybody has an issue with it being recorded.
Yeah, when they press recording, it appears on everybody's screen to
you have to acknowledge it.
Yeah, so when you agree, it then records. So Zoom has built that into it.
Thank you.
Okay.
I think we better start. It's 4:03. I think we get started because I know Dr. Ajayi and Dr. Jide, they are just from work. So we don't want to drag them more than we can. I think we better just get going.
Okay, sure. That's just give me 1 minute. I'm just picking the agenda. Okay, so just so that we get going and we go quick, I want to welcome everybody to this program. And we would typically start with a 1 minute prayer or thereabout, but it will be a silent prayer and everybody prays in a way they understand or appreciate for this program to be successful. So starting now, we'll just take 1 minute and anybody that wants to pray can. Okay, may God accept and make this meeting a successful one for us, and may we gain from it. Okay. Amen. The next thing on the agenda is to have the president give a short speech on this program. And Ellen, over to you, please.
Thank you, sir. On behalf of the board of the African and African Descendants Friendship Club of St. Albert, we want to say thank you to everyone that has come to participate in this event. And we want to thank the doctors that have made themselves available to volunteer their time to educate us on health. And we believe this event is part of us supporting ourselves, which is the objective of our association. Our association's objective is projecting African culture and history to people of St. Albert through events, supporting each other and volunteering. So this is part of supporting each other in giving us information. And we hope everyone will learn from this event. And we say, feel free to post in your questions to Dr. Jide and Dr. Ajayi and every other, if there are other colleagues will be here. So once again, thank you so much for joining this event. Thank you.
Okay, thank you, Ellen. Without further ado, we'll go straight into, I'm supposed to get some information on this, but I've been sidetracked. So I'm going to ask Doctors Jide and Ajayi, and I'm not sure if the doctor is online, to give us a quick introduction of themselves and their clinic so that we know more about it. All we know is that you guys have a clinic in St. Albert and it's called Gateway Clinic, and it's one we should all be patronizing. So I would give the floor to you guys to do like a 2-minute introduction and of yourself and clinic, and then we go straight into the program. Thank you.
Well, okay, let me start while my colleague is trying to take care of himself. I'm Dr. Ajayi. I have been practicing for around 28 years now. I came down from England. I trained as a family physician and also as a psychiatrist in England, but I've been doing more of family medicine in Canada. So we started the clinic in St. Albert roughly about 5 years ago, but I joined fully about 4 years ago. And the clinic has been running well. Presently, Dr. Alfred is accepting new patients, but in case Dr. Alfred is busy, I can also chip in and accept walk-in patients. And the person that started the clinic initially was Dr. Raymond Asongwe, and I believe he's going to join us very soon. So that's a summary of myself, but if you have any questions, I'm ready to answer. Thank you.
Thank you very much, Dr. Sorry, I was just logging in on another device just to make sure you can see my screen, and I'm sure it looks like everybody can see the screen, correct?
Mm-hmm.
Yes, we can. Yes, we can.
Okay, so I'm Dr. Ajayi Jide Alfred Ajayi, like Dr. Ajayi said. I've only joined the clinic about a year ago, but I've actually been 2 years in St. Albert. And I moved over to Gateway Family Medical Clinic. Before then, I was in DX Medical. The person you can see in the middle of the screen there, can you see the pictures? That's the three of us there. I'm on the far left. That's facing you will be the far right. Dr. Raymond Asongwe is in the middle there, and he's the one who started Gateway Family Medical Clinic here in St. Albert, and Dr. Ajayi, you can obviously see on the left. The clinic in its space where it exists, which is on Herbert Road, has actually been here for about, I believe about 30 years in total, 25 years, something like that. It was run by Dr. Mongam Pong. For those of you who've been in St. Albert for a couple of years, you might be aware of that. So, like Dr. Ajayi says, I'm accepting new patient. Dr. Ajayi and Dr. Asongwe have quite significant panel, but they do chip in every once in a while if I'm sort of not available and stuff like that. So that's just by way of introduction. Dr. Asongwe obviously knows a lot more, and I'm sure he's going to join. I don't think he's on at the moment yet, but I believe that he.
You can't see me. Sorry.
Oh, sorry, I couldn't see you on the profile. Yeah, so I'll pass it on to the person that should be speaking, Dr. Asongwe. I'll come back and do the the startup of the health talk. I want to commend the organizers of the health talk. Because this is something that's fairly important. I've only been 1 year in the practice, but I've not seen a representative size of our people. So when I say that African descendants coming to take benefits of these health screening programs, which is completely and fully funded by ABADA, government, doesn't cost anybody a dime. So it's quite important that we have these discussions among ourselves. I'll let Dr. Asongwe give a bit of background as well.
Can you see me? Can you hear me?
Yes. You can hear, but yeah, I'm sharing my screen.
Oh yeah, sorry. Okay, just proceed. That's okay. Yeah. So I'm Dr. Raymond Asongwe. I was born in Southern Cameroon. I trained in Nigeria, and I worked about 14 years in England, and I have been working here for about 7 years. I started in Edmonton and then moved to St. Albert in this location where we've been for about 5.5 years. I don't need to go through what my two former colleagues had already outlined. So we accept, just to be clearer about accepting patients and not accepting patients. Accepting patients mean officially you are registered with the College of Physicians and Surgeons of Alberta, that you are accepting patients from anywhere. But as family and friends, we continue to accept patients from relatives and friends of existing patients. So those of us in this group would be considered friends and family. So that means anybody who wants to come and see Dr. Alfred or Dr. Ajayi or Dr. Songwe is very, very welcome to come and see us, because that's why we're here. I will leave Dr. Ajayi to proceed with the introduction for the training programs, and then I believe she is going to present the general screening program and health prevention, and then I will present something on cancer of the colon and cancer of the cervix, and Dr. Ajayi would present something on the rest of the screening programs that we have in Alberta.
Thank you very much, sir. So this is the plan. Just like we have said, we would have the next 1 hour, 10 minutes thereabout, or 1 hour plus for the whole program. We are thinking that it is all broken down into about 5 sections. We have the annual medical checkup, we have the fit session, we have the pap and mammogram, we have the prostate test, and we have other benefits of other medical services and vaccines and vaccinations. So the plan is that depending on you guys, you want to take each session, and then we ask questions on that session, or we want to go with it and go to the end. But that is the areas we want to cover, and we have the next 1 hour plus. So Dr. Ajayi, over to you guys, and let us know if when you are done with one topic, do you want questions, or do you want us to wait till you have done all the presentation? Whichever approach you take is good with us.
Yeah, thanks a lot. I hope you can hear me all. I would suggest that. Can you hear me?
I hear you very well. Very well.
Okay. Yeah, I'll suggest that maybe people pencil their questions down if you've got a note or a leaflet, or make a mental note of it, just so that we can go through it, and you can then ask your questions at the end and can be all cohesive. The whole I apologize in advance if this seemed like a lot of information sort of overload. We'll try any medical jargon so people can understand us, but and we'll be talking about things that might appear a little bit scary, so cancer and things like that. But these are things that we need to pay attention to. It's like when the insurance man is talking to you about life insurance, and coming from where we are, we say things like it's not my portion and stuff like that. But these are realities of life. These are realities of life, and we have to take steps to prevent them. Okay, so I'll start with this just as a
sorry, doctor. Before you continue, the other thing people can do is to put their questions. You can put your questions in the chat room. Yes, yeah. We will check it. So please, let's go with that. Yeah. Okay, over to you, doctor. Go ahead. That's a good.
Put your questions in the chat box, and then somebody will monitor it and let us know. Okay, so by way of disclosure, I've picked the slides from the Alberta sort of government website. There's something I would call the ASAP screenings, which is the Alberta Screening and Prevention sort of program, which is in line with the what we call the top guidelines in Alberta. basically what we call best practice to make sure we have a healthy population. So what I put on the screen that you can see is what we should be having, okay? So it tells you what screening maneuver we should be having. It tells you what age should be having it, and how often you should be having it. So blood pressure, at least you should have your blood pressure check at least every year if you're 18 years and above. And I cannot tell you how many people that have come to register with me and have picked up that they've had blood pressure because they've never checked until they go to a doctor. They never knew they had high blood pressure. Height and weight, very important. Why? Because that's how we know whether you are in the correct weight for your height, what they call the BMI, body mass index. Now, why is blood pressure, height, and weight important? As you're going to see in a later slide, there's very high, we call it prevalence. That means the amount of people living with cardiovascular diseases, i.e., undiagnosed hypertension, a heart attack waiting to happen, a kidney problem waiting to happen, stroke waiting to happen. These parameters help us to, so if somebody is at a BMI of, there's a range for it. Usually normal is like 18 to 25. If your BMI is coming right high, I'll be telling you when you come to see me that you should be doing exercise, which is the next one that you see. You should be having, you should be walking around, you should be having healthy diets and all of that. Okay. And every year we're supposed to ask questions. So don't be annoyed if we ask you whether you smoke. We all know that smoking is a risk factor for a lot of stuff. Influenza vaccination, very important. That should be annual. My colleagues, I believe either myself or one of my colleagues is going to talk about mammogram in women. So that mammography is it's a kind of photo, a kind of imaging. We call it imaging, but essentially it's a photo that looks at the breast to try and detect early breast cancer. And all women between the ages of 50 and 74 should be having that at least every 1 to 2 years. There are people that have it more often if there's family history of breast cancer. There'll be younger people that would obviously suggest it to, if, for example, they feel a lump in their breast or, they're unwell or they've got a very high family history, what we call first degree family history. So if your your sibling, brother, sister of same father, or your immediate parents have breast cancer, then we'll be suggesting that you have it earlier on. Same thing goes with colon cancer screening. And it's a very simple test we do in Alberta. We do what they call the FIT test, which we call immunochemical test. Essentially, it's just, you take a poo sample and you smear it, and then you send it off. It gets tested, they look for blood in it. And if there is blood in it, then you go and have the next line, which is the flexible sigmoidoscopy, which is essentially putting the camera through the bottom and looking into the gut to try and look for any evidence of changes. It can be just a non-cancer growth that we call a polyp, or it could be a cancer growth. And then colonoscopy, which is obviously going a bit further. Okay, and there's the pap test again for women. Everybody that's aged 25 to 69 should have that done. If you're 21 to 24, it's optional. If you're sexually active, and less than 24, we generally not suggest it. But if a 21-year-old comes to me and says they want to do it, I'm not going to refuse them. We should be checking we come to the annual bloods now. The most important one here is the lipid profile. So that's your cholesterol. People talk about cholesterol a lot. Cholesterol, non-fasting cholesterol, fasting cholesterol doesn't matter. And then we'll calculate what they call a cardiovascular risk profile. And everybody that's over 40 should be having that done. There's a reason why it's over 40, because they've done research and found out that if everybody just does that's not less than 40, there's probably no benefit. Okay, and then that should be at least once every 5 years, as the same thing with cholesterol, and calculating what they call a cardiovascular risk profile, which I'm going to talk about more in detail as we go on. And then we talked about, and there should be diabetes screen, so i.e. they're checking for a very simple test. If fasting glucose, we give you a blood work requisition. You go to the lab, they check your glucose, they check what they call the A1C, and sometimes we can calculate the diabetic risk. Okay, sorry, that's a lot of stuff, but that's it on. You can take a screenshot if you like. You're welcome to keep that. Okay, this is just the same thing I've said, and how often it's used. Again, it's from the Towards Optimized Practice Guideline. These are not my slides. These are slides from the Alberta and national data pages. So blood pressure we should be checking that, as I say, every year. And then they talk about a bit more about your height and weight. It helps you with calculating, cardiovascular risk. How often should you exercise? Who knows? How often should you exercise? We should exercise every day, or at least minimum 5 times a week. Okay, and when they say exercise is at least something that breaks a little bit of sweat in you, and you keep going for about half an hour. Hands up if you're doing that every day. But that's what we should be doing. Okay, and it's important to have these discussions, so that we just don't drop. That's how back home we say it was okay last night, and then it just dropped. It's usually more often than not cardiovascular diseases. It's not some juju somewhere. Okay. Tobacco smoking, that should be assessed as often as possible. In this clinic, we tend to do it every time people come in. Okay, I'm aware we're 30 minutes, so I'll speed up a bit now. Colleagues too would like to talk. Okay, so this is just some evidence as to why, what the evidence is. Basically, we're doing the cardiovascular risks from, so when I say cardiovascular risk, sorry, I'll keep flipping between these things, but it's these ones that we looked at: the plasma lipid profile, we look at your fasting glucose, and we look at the HbA1c. Obviously, when you come here, we don't limit to that. If you're coming for the first time, we do a bit more stuff. We do like your thyroid, we do like your blood count, because I know that where we've come from, a lot of people have like sickle cell anemia undiagnosed. They have anemia from other causes. So we do all this blood work and we get all that checked as well. So that was where I was up to. It's been proven. The study has been done actually to say, if you have two group of people, somebody that is 40, 50 getting this test done and somebody not doing it, is there actually any benefit? Is the person that's not doing it going to die before the person that's doing it? Obviously, there's several mortality, as we call it in medicine, which is death, or morbidity, which is disease, is multifactorial. But what you're trying to do is preserve adverse incidences from happening. Okay, so but generally, when they did do those tests, they did find that people that were testing and checking regularly were more likely, number one, to pick up risk factors earlier and therefore avoid disease and death earlier. Two, in the event that they do have disease earlier, because they're getting regular checks, they're less likely to suffer adverse effects, i.e. long-term disease and deaths from regular checks. So it is beneficial. And that's why the government is paying for it. You don't pay a dime for it. The government wants a healthy population. They want healthy workers. So it's all fully funded as long as you're a legal resident in Alberta, whether you're temporary or permanent. You get an Alberta Health Service number. Okay, there are other things. It's not just blood work. There are other things that we need to do as well. So we need to make sure we're eating healthy diet. We need to make sure that if we're smoking, we're cutting it down, or we have plans to quit. If we're taking alcohol, we need to cut down and make sure that we're staying under the limits. If you have more than two to three drinks a day, then you're in England. Sorry, the three of us are trained in England, so we use the English units. So for men, if you're taking more than 21 units a week, for a lady, if you're taking more than 14 units a week, which is basically 1 or 2 drinks a day, then that's too much. And then physical activity I've explained as well. Sorry, these are all medical things, but I just wanted to provide a bit of a background as to why these things are medically informed. Okay, I think that would be, okay, I think I've got one more slide for mine. In terms of reducing your risk, it's not all about cholesterol. Cholesterol is important. And if you are picked, so people that are in the yellow and the red zone, once we calculate what they call a risk profile, so we look at your cholesterol, we look at your blood pressure, we look at your height and weight, age, and we plug that into a calculator, that will tell us whether you're in the green or the yellow or the red. Obviously, so yellow would have a discussion with you whether you want to go on a medication to reduce your risk that will bring down cholesterol. And as you can see in that place with the green hand, with the green thumbs up, it's saying there's a medication that's called statins. If you take it, it's going to reduce your risk of heart attack by and stroke by at least 25 to 30%. So we would offer those kind of medications to people and, and see whether they're interested in it. Okay, and then we'll have discussions about it. But it's not just all about, just taking cholesterol tablet. There's also stuff that you need to do. So again, exercise, very important. Okay, I think that's the end of my slide there. So I don't know if Dr. AJ wants to talk about mammogram, or you want me to go on?
Yes, let me chip in on mammogram.
Okay.
Sorry, Dr. Ajayi, can I make a suggestion? Because I sense from Dr. Ajayi's presentation that people might not take away a lot going on because there's too much material to digest. I suggest we just present an overview for 2 minutes or 3 and allow people to ask questions and interact so that we can answer them.
I agree with that.
I think that way they're likely to take home more.
Yeah, I agree.
Okay, so let me just chip in on mammogram because there's something important about mammogram. Now, in the last 5 years, things has changed about mammogram, especially for our ladies. Now, they discovered a few years ago that some ladies have mammogram and they still develop breast cancer, and it was not picked up on mammogram. It was a big medical legal issue in USA. But on probing the lady that was involved, they now discover that the ordinary mammogram may not pick up most of the breast cancer. So there is a new method of mammogram which they now do. But before they go ahead with that type of mammogram, they will have made a difference between the breast tissue. If a woman has a dense breast tissue, they now do a mammogram with tomosynthesis. That one is more reliable than the normal mammogram. So what I usually tell the patient is that if a woman comes to see me and they make a report on the mammogram that she has a dense breast tissue, what I usually tell them is that if you are going for a future mammogram, you must always let the doctors know that you have a dense breast tissue so that you can go for mammogram with tomosynthesis, which is more reliable way of screening for breast cancer in those age group. So then the other thing which I need to chip in based on my experience in psychiatry, though it's a very controversial issue in Canada, is cannabis. Now, one thing I want to let you know, as especially immigrants or second generation in immigrant, there is nothing good about cannabis. And there was a documentary on CBC a few years ago where they analyzed the effect of cannabis on our young ones. So I think if you're going to take anything home and somebody is trying to convince you that you use cannabis for cancer or use cannabis for chronic pain, just know that as at now, cannabis causes more harm than good, and we must let our young one knows about this. So that's my message.
Very well said, Dr. AJ. I appreciate that. Thanks a lot. Yeah, those are very valid comments, and I'm just gonna. I see some questions in the chat box which I'm just gonna quickly sort of answer. The first question there is that how often is it recommended to do a mammogram, please? So that's what I'm sharing now. So basically, if you're between 50 and 74, you should have a screening every 2 years. Okay. Now, what does that mean? It means that that's the minimum. The minimum is every 2 years. if you're between 50 and 74. If you come to me like a year and say, look, doctor, I want to have am I going to say no? I'm not going to say no, because like Dr. AJ said, these are screening procedures. They're not 100. What you have to remember in medicine is that nothing is 100%. Okay, so even if you've been having regular mammogram, it doesn't mean people cannot still develop breast cancer. What we're doing is that we're trying to reduce the chance to as small as possible. So if you came to me and say, look, doctor, I know I had mammogram, I want to repeat on this year. Of course, we're going to do it, no problem. If you come to me at 6 months, we can have a discussion. I might do something else if you have concerns. Obviously, that precludes if you find something in your breast, or so the things that I don't know whether the other slide shows it. No, it doesn't. But there are things that you should pay attention to. So I'm starting to speak to the next question, which says, can you speak a little bit more about breast tissues? There's some, which is why I've put this now. If you're doing regular self-breast exams, which is recommended for all women, you should do it at least once. So in those space of time when you're not having mammogram, you should do at least once a month, 2 to 3 days of your period, you should examine your breast, and it shows you how to examine your breast. So essentially, the breast is a mammary tissue. It's actually full of fat. It's adipose tissue, and it's just that it then has glands that are specialized. The glands are specialized for milk production. That's the difference. And obviously, being a woman with the hormones that you have, it comes out bigger. Men too have breasts, and we have some adipose tissues in there, and what they call rudimentary or atrophied breast ducts, but obviously so they don't provide milk, and because we don't have all those other hormones, we don't get milk. Some men do get milk in their breast, and those are things that we should talk about. It's not unusual to have it in puberty. But to answer the question, yes, so the breast is a mammary gland. You should have your mammogram done at least every 2 years. If you come earlier, we'll do it. What about those that are not up to 50? If you come to me at 45 or even 40 and say you want to have a mammogram, we would have a discussion. I might do it. It's unlikely that most doctors will say no, because then if we say no and something happens, then the liability is more. We might say, okay, instead of mammogram, let's do an ultrasound. Okay, and the picture on your screen is showing you how you should check your breasts. You go up and down, you go where you go cycle. If you feel anything, so if you feel a lump or there's an abnormal change in the skin, so the color, if you see an abnormal patch of skin different from the color that you normally have, if you see a dimple in your breast, if you are not breastfeeding or pregnant and you're having milk coming out of your breast, if there's blood coming out of the nipple, you should come and see the doctor. So I've talked about lump, I've talked about change in the skin of the breast, I've talked about dimple. Okay, any kind of discharge, if you're not pregnant or breastfeeding, it should be seen by a doctor. I hope that answered the question. And that's what they do in a mammogram. It's something that presses the breast together, and you can see a picture by the side there. You see that sort of more whitish dots. It gets them to investigate it a bit more. Okay. I want to slow down and let people ask questions, just like Dr. Asungwe suggested.
Can I just chip in something just before you allow the questions regarding the mammogram? I think we had a discussion at the Cancer Institute here in Edmonton a few years back, and in a presentation that about breast cancer screening, and there was very clear statistic that there's a disproportionately high number of ethnic minority deaths from breast cancer, and the reason being that they are much less willing to do screening. And by ethnic minority, they mean Africans, people from Middle East, essentially, basically mostly people from the underdeveloped countries, and especially, so some of them are usually barriered by their beliefs. So if you don't want to be examined by your doctor, for example, you come to Gateway Family Medical Clinic and you are not comfortable with Dr. Ajayi, myself, or the others examining you, there is a clinic for where we refer you to go, dedicated to see people like you who would prefer to go and see, for example, a woman who would prefer to see only a female doctor for a pap smear or breast examination and so on. So we take care of that. We do not risk it because you don't want Dr. Ajayi or Dr. Ajayi to examine you. Please come and ask to be referred to that specific clinic. They diagnose quite a large number of patients, especially from the Middle East, with stage 4 breast cancer, who never got examined or never had mammogram because they just didn't look at their breasts and they didn't allow their breasts to be examined. So just to be aware of that.
Okay, we'll entertain
Okay.
we'll entertain questions now. I think we still got some time here. And what you can see, sorry, I've just finished. What you can see on your screen is actually, you see that as the age increases, there's increasing risk of breast cancer, which is why you know, the mammogram is for that age group. Yeah, sorry, whoever was speaking, can you carry on, please?
Sorry, I just wanted to ask my own question and I didn't want to type it. But you did say something about men having also those tissue. Is it like the mammogram is for men too, or are men susceptible to breast cancer too?
I'll go first. My colleagues can chip in later. So yeah, men can have breast cancer. In fact, I think about 3 or 4 months ago, I diagnosed a gentleman with breast cancer. And what was noted that he just started to, what was it? The wife had noted that the nipple had turned inside a little bit. This is a Caucasian guy, you know, hardworking, goes away, you know, but, you know, we checked it out and it was breast cancer. But what informs, so most of these things are sort of public health informed, and what informs screening procedures is they look at, is the vast majority of people going to get benefit from the procedure and who is going to get the most benefit? And that's how they determine what people or what age group should have cancer. Same thing is why, you know, 18 years old, 19-year-olds don't have PAP. It's they found out that the women are the ones that are most likely to develop it. Okay, you would have the odd 1 or 2 men that would develop it, but is it what subjecting every man to go and have a screen test? No. So that's how they inform, that's why they inform screening procedures, right? That's how they inform screening procedures. So that's why men are not having mammograms. But if you do have concern as a gentleman or as a younger person about your breast, please come and find us and we'll take it up. Okay.
I have a question. Can I go ahead?
Yes, please.
Go ahead.
Okay, thank you very much. Thank you, Dr. Alfred, Dr. Ajayi, and Dr. Raymond for the presentation so far. I wanted to ask this question. You know, people come to your clinic, Gateway, and maybe sometimes you send them for blood tests. I want to understand, like, especially for men, what are the most common issues you find out? You know, I know we have to keep some privacy, but in general, what are the most common issues you find out with most men, and what should they do? What advice do you have for them, you know, to ensure that they don't get into that situation?
Dr. Ede, do you want to take that, please?
Yes. If I talk of people from the African origin, I still notice that majority of them are not aware of prostate cancer, which has a higher prevalence among the African immigrant. So most of the time, if I talk to people in their 50s and above about it, some of them are not so keen. And some of them, they have this myth about prostate cancer, saying that, oh, if they go for treatment, they will lose their let me put it in a simple way. They will not be able to perform well as a man. That is a big issue. Then the other issue that is common among African is high blood pressure. And there's also a myth about treatment also. A lot of men believe that if they start medication for high blood pressure, they will not be able to perform very well, even though some of the medication has some side effect, or which is linked to erection problem. But there are so many medications we can use to sort those problems out. So those are the two big issues. I'm not only here in Canada, because I do go to Africa for some medical outreach. And I noticed that the same problem persists. Also with diabetes too. Same thing. So I think what we need to do is that we continue to educate some of these people that has this myth about getting treatment for prostate cancer, getting treatment for high blood pressure, and getting treatment for diabetes. And I think the more we educate them, the better.
Good, thank you.
Yeah, thanks very much. Yeah, so yeah, thanks very much, Dr. AJ. Yeah, so yeah, like I said, common ones are, obviously we pick up a lot of high blood pressure that people are not aware of, which again has risk for stroke, heart attack, and kidney problems. So we pick that up early. You start medications. We pick up diabetes. We might pick up some prostate issues as well as a common one. There can be other things that we can pick up. Thyroid, we do an EKG, which is the one that you go and get stickies to your chest and stuff like that. We can pick up elevated BMI, things like that. So we pick up quite a few. Dr. Raymond, is there anything that you wanted to add?
Oh, you mean in terms from the last question, from investigations that we send you? Generally, we have like a standard set of investigations that we do in our annual blood checkup. Like for men, we do prostate, we check for diabetes, we check for cholesterol, we check for blood cells, which is can be an indirect way to diagnose some cancer by just counting the blood cells. And then we do the ECG, which is a heart tracing to see. Sometimes sometimes it will be the method that it will be the first time that somebody has done an ECG in his life at 50 maybe, and then we pick up something that directs us to something. For example, a heart condition that is common, especially in Black people, can suddenly appear on an ECG and then leads us to further investigations. Or even sometimes we pick up people who have had a heart attack and never knew that they had a heart attack, and we see it for the first time, and we retrospectively diagnose a heart attack by doing like a stress test or angiogram. So those are things that we generally find when people go for investigations. That is apart from this other screening things that we presented, i.e. the cervical cancer, breast cancer, colorectal cancer, as well as prostate cancer.
Perfect, thank you. More questions, or should we just move on?
Yes, there's a question in the chat. Someone is asking, why should I screen for colposcopy? I don't know if there's a question.
I will take up that one.
Yeah. Do you want to share? You have your presentation ready, Dr. Raymond?
I think it's very extensive, but it'd be easier for me to just explain.
Okay.
The literature is too much on that subject. So why should I screen for colon cancer? Okay, number one, colon cancer is only after lung cancer. It is the second commonest cancer in men in Canada, and it's very common. If you can imagine, 1 in 13, if you stand amongst 13 people, 13 men, one of them would have colon cancer. That is a lot in medical terms. That is a very high statistic. So colon cancer is screening is very, very important. Beginning from about 2010 in Canada, when they intensified screening for colon cancer, there has been quite a significant decrease in the number of deaths from colon cancer. Why? Because most colon cancer, before it becomes cancer, starts with something, a little growth in the colon, they call polyp. It starts growing, the polyp starts growing, and if we can attack the polyp and remove the polyp, that stops colon cancer. So if you are very diligent and you go for your colon cancer screening every year, your chances of avoiding colon cancer are very high. Well, almost 90% of cancers, colon cancers, start with that polyp, and once they remove that polyp, it can prevent colon cancer. So that's one reason why you need to go for colon cancer screening. The other reason is because the risk factors for colon cancer, they tend to increase a lot, especially in Africans when they come over this way. One of the biggest risk of cancer, colon cancer, is red meat. Believe me or not, it's red. And when we come over to Europe, we eat a lot of red meat. You're increasing your chance of having colon cancer. So those are things that you have. Those are reasons why you need to. There are a lot more risk factors for colon cancer: smoking, obesity. That's the other thing too. Most Africans who come to North America increase their weight, and that's a big risk factor for colon cancer too. So that's in summary why you need to go for colon cancer screening.
Yeah, so thanks very much for that. So that puts everything really there in perspective. And someone was saying, why do I need to screen for colonoscopy? So the colonoscopy is a screen for colon cancer, but it's not everybody that goes straight colonoscopy. I know some people may be.
I'm sorry, good. You said colonoscopy. I answered colon cancer.
Yeah, but you're right. What you said is right, my chief. So there's a simple, you don't have to go straight to colonoscopy, because I know that's invasive. You probably have to go on a general aesthetic to relax you, and then they put a camera up the bottom. But what we do is what they call, this thing I'm showing on the screen, which is called the fecal immunochemical test. And what they do is that it's a stool-based test that relies on detection of blood. Okay, so before it used to be what they call, I believe still back home, they still call it the fecal occult blood test. So occult means something you don't see with your eye. But the very more advanced here, and it's the fecal immunochemical test, because they found that it's sensitive. That's what that thing is actually showing. Comparing FIT versus FOBT, which is fecal immunochemical test versus fecal. And that's just all jargon. Don't worry about it. You don't think that if we're going to screen for colon cancer, then it's going to be straightforward to colonoscopy. There are some people that will be straightforward to colonoscopy. So those kind of people will be people that have their family, their immediate family, i.e. brother, sister from the same parent, or their dad, mom have had colon cancer. Then there'll be no point doing it. We'll just go straight to colonoscopy for those people. But for the general population, everybody above 50, it would be in your annual test, we will do the FIT test. So when we give you the form, you take it to DynoCare or DynoLife. They will then give you a kit, which you then take home. You do by yourself. You put a poop, or you do a poop, and then you put it on the stain, and then you mail it out, and the government sends you the result. Somebody is asked on the chat forum, what are the symptoms? By the time you're getting symptoms, it's too late. Okay, the whole idea of this is for you not to have symptoms. But yeah, there will be people that I've picked up a few, one or two. I'm sure Dr. Raymond and Dr. Ajayi have picked up a few. So you might, if people are having persistent diarrhea, in England is a 2 weeks rate referral. If you're over 60 and you're getting persistent diarrhea, I believe it's 4 weeks. Correct me if I'm wrong, guys, but I believe it's 2 to 4 weeks. If you're having persistent watery stool, or in fact any change in bowel habit. So, but it's just that change to more loose bowel is more sensitive. But if you're also increasingly getting constipated than before, and you're over 50, or then you should be worried, over 40 for that matter. If you can see visible blood in your poop, if it's bright red blood, it's more likely to be maybe like something like a pile or a tear. But if it's darkish blood, or your stool is suddenly darkish and you've not had green vegetables to eat, or you're not on iron tablets, then you should come and see us. So that's just a brief. I don't know if I answered those questions.
Just to add because I have a lot of people who come and ask me, oh, I have had piles for 30 years, so I can see blood. So what's the point going to test my poop for colon cancer, because you're going to see blood anyway? No, it doesn't necessarily work that way. If you look at the test that Dr. Ajayi displayed on the screen, it has a specificity to diagnose blood that is coming from the polyp that I told you about, or from the cancer. So that test, a lot of the time, is able to differentiate between blood that is coming from a bleeding pile or hemorrhoid and that one that is coming from a cancer or a polyp. So if you have had a laceration, which they call, or a cut that they call fissure, and you're bleeding, or you got hemorrhoids and you're bleeding, still come for a fit test, because the fit test can still tell you whether or not you have a polyp or a cancer.
Okay. I'll just answer this quick question before we go to the next thing. Somebody's asked, what is the A1C test? So it's actually HbA1c, which a lot of people call A1C. And the whole idea is that it's the glycosylated hemoglobin, and it was found a lot. We used to just do the fasting glucose test, which is essentially the screening for diabetes, right? So it's something that came out, I think, a few years ago now. We used to be able to just send it to the lab, you do a fasting group, you fast overnight, and then you do the blood, or you go and do a random sugar, and it's very hard, and we send it fasting. Now, because the A1C is a more long-term measure of diabetes, of elevated glucose in the body, they brought it out. Essentially, it's that some glucose molecules attached to the hemoglobin, and then they measure that aspect of it. And the whole idea is they're supposed to give us a more longer snapshot of what your body sugar is doing, whereas the fasting and the random one gives us a snapshot. Those one, they give us like a longer sort of a picture. We tend to use it more to monitor response to medication as opposed to diagnosis, but you can also use it for diagnosis. I don't know if my colleagues have anything to add, but that's like a summary of it.
I guess in simple terms, I guess what Dr. Ajayi explained was that the A1C is a dependable way to measure diabetes, because it does not change over a long period of time. It can remain the same over 3 months, but the sugar will change depending on what you eat. So we rely on that in terms of monitoring glucose.
Okay, just looking at our time. So we have another couple of minutes to go to cervical cancer. Does any of my colleagues want to do that, or should I just shoot? Okay. So the background for cervical cancer is it's very common, even more so among women of African descendants, and just like prostate cancer. And so, because of how common it is, Canada decided to start screening, just like many other countries do. And you can see the figures there that before then, the incidence was quite high and the mortality was quite high. So the incidence is 1 in 70 women will get it. And then 1 in 100 would die from it. But since they've started to do it, the numbers have dropped drastically, and because we're picking this up, and there's a screening test for that, which is what we're going to talk about next. Oh, so why cervical cancer? The truth of the matter is, once young people start to become sexually active, the girls, there's a very high prevalence of what they call the HPV, which is the human papillomavirus, and it causes some changes within the cervix, and that causes cervical cancer. You see that graph there. It shows you starting from age 15. Young girls starting to become sexually active. She gets HPV infected. The body might deal with it and it goes back to normal cervix, but sometimes it doesn't, and then it progresses to what they call a precancerous lesion, and then people can develop cervical cancer, and that's the reason why in Canada, I think younger girls age 13 to 15, I believe, or from age 13 they get that HPV vaccine, just to reduce the incidence of HPV in those age group as well. So this is breast cancer. So that's just a simple anatomy of the cervix. Okay, so it's the female genital tract, so the vagina, and then that's the uterus, and then the neck of the uterus and the mouth of it. So when we go to look, we see the cervix, and then we'll just do. This is essentially what we do when you come for that smear. That's the brush. It's called the Sato brush. Before it used to be a spatula, but now they advanced it. You're in that position, which is the total patient. Lady is lying in the blue apron, and then her legs are open, and then we use a speculum to open up the vaginal canal, and then you stick in the brush, and it goes round and round and collects cell from the neck of the womb, and then we send that off to the lab, and it's a very sensitive test. We've picked up a few abnormal sample. When at that stage, when you pick up the cells, it's not cancerous yet, so that's why it's called a screening test. So the whole idea is to, before it becomes cancer, again, if I go back to that graph, before it becomes cancer, we pick it up at that stage where you got the slightly light blue. After the cup goes up, we'll pick it up at the precancerous stage. So what we then do is we say, oh, these are abnormal cells. We'll send it to the gynecologist, and they can burn off those cells. That's in the procedure called a LITS, or before they burn off it, they look at it more closer with a more bigger lens. It's called colposcopy. Basically, it's just a big camera, and they're looking very closely at the cell and see where the problem is. If they're not satisfied with what they see, they then go and do what they call a cone biopsy, or they burn off the cell in a procedure that's called LITS. Okay, and so it's a very important test that all we're having. Again, at the beginning, I think I showed the age. I'll probably go back to it. Sorry, let me go back to the age is from 25 to sorry, I'm flipping the screens now, but I just want to get back to the age that needs to do cervical cancer. So that's the age. You're supposed to do your pap test between the ages of 25 to 69. You do it every 3 years. If the samples come back abnormal, we'll then send you for. Sometimes it's not all samples are abnormal that has to go for colposcopy, which is the one that you look at it more closely. Sometimes if just a little bit abnormal, we'll tell you to come back in 6 months or 1 year, then we'll repeat it again. And if it's still abnormal, then we'll send you for that one. Or if it's still not sure, we might tell you to come back in another 6 months. There's clear guidelines, so we're not just doing guesswork. It's like an algorithm, it's like a table. If A happens, go to B. If B happens, go to C. And we'll follow that algorithm like a religion. And so that's what happened. If you're between 21 and 24 and you're sexually active, you should have pap smear also done. If you're less than 21, you probably shouldn't. But again, if you have concerns and you come to ask me point blank, would I refuse? It starts to get into sort of murky waters. And if I'm thinking, well, if this person develops cancer, it's going to cost me a lot of headache, I'll just do it. So that's generally like a summary of it. We just want to give room for question. Again, I want to re-echo what Dr. Asongwe said. So if you're not comfortable, because there's just me, Miss Dr. Ajayi and Dr. Ajayi, we're all men. We probably will get nurse soon. I'll be doing PAP. We're in the process of that. But if you come and you're not happy with it, or you're not happy but not comfortable with a gentleman doing your PAP, then there's referral services that we can send you to for both the PAP and the breast to get it done. I don't know if my colleagues want to chip anything in.
I guess what I would have liked to chip in goes to the general presentation. As a matter of fact, like all the screening procedures, and that will be, we actually talked of how you do them and why you do them, but we haven't spoken where I was thinking some people will ask us questions. So, but since there are no questions about that, we can proceed to present or to talk about prevention, how we prevent these things from becoming positive at all. I can talk about cervical cancer. How do you prevent cervical cancer? One of the ways to prevent cervical cancer, as Dr. Ajayi already presented one of them, and that's screening. The government starts screening, sorry, not screening, immunization, immunizing children in grade 5 and in grade 9 in Canada, in Alberta. And I'm not too sure about other provinces. So that's one way to prevent it. But that this immunization it does not prevent you from having the screening. A lot of people who are vaccinated with the HPV vaccine will still get cervical cancer. So you still have to continue, but it does reduce the chance of having cervical cancer, but it does not prevent it completely. The other way to prevent, obviously, is one of the commonest causes of cervical cancer, paradoxically, somebody is well, I wouldn't say paradoxically, it's having multiple sexual partners. So somebody a young person who starts off and having several partners is more likely to catch the HPV virus. So a young person who has, say, by the age of 25, who has had sex 1,000 times with the same partner does not have any increased chance of having cervical cancer as a person of the same age who has had sex 100 times with 100 different partners. It is much more likely to catch the HPV virus, which is the precursor or the one that leads to cervical cancer. So that's a preventive measure. Hygiene is also important, and genital hygiene. Women who have recurrent infections in the vaginal area, genital tract, are more likely to catch the HPV virus. So I think as far as prevention for cervical cancer, preventive measures, that's as much as I can remember. If you can remember any of them, colleagues, can you? Some of them are screen relevant.
Yeah, I think you've mentioned quite most of them, Margaret. So there's a question in the chat box. Maybe Dr. Ajayi wants to speak to that. It's asking what intervention, maybe somebody's, I believe this is a question from before, but maybe applicable to this presentation as well, is what are the symptoms of, cervical cancer if they do occur, and what are the interventions that are available or accessible in Africa? They're specifically asking in Africa and where, Dr. Ajayi. Okay, now let me just repeat the question just to make sure that we get the person right. The symptoms of cervical cancer, I believe that's what the person wants to know. Yes, as well as what intervention they can get and where. Okay. Now, in Africa. Okay. Now, based on my clinical experience and documented evidence, majority of ladies with cervical cancer, they usually present with post-coital bleeding. What that means is that a lady will have sex, and after sex we notice blood. Some of them will notice some vaginal discharge, and some of them may have pain during their period, but that is not common. So, but the commonest one is the post-coital sex. That is after having sex,
they notice blood. And once we notice that, we usually escalate it, refer them to the appropriate service that will help them. In some situation, like people that doesn't usually go for screening, when the cancer has spread, they may begin to lose weight. And we have a popular main minister in Nigeria that actually died from that. They will be losing weight, and when a good doctor tries to do a thorough physical examination, that they will pick it up and discover that, oh, this person has an advanced cervical cancer. So, but the commonest one is vaginal discharge, post-coital bleeding. And when it advances, it can lead to either pelvic pain or abdominal pain. So those are the symptoms.
Thank you, Dr. Ije. So in regards to what facilities you have in Africa, I believe all countries would have this facility, including Nigeria, Uganda, Cameroon, Ghana, whatever. It's just because maybe a lot of people may not be accessing service. I do know, I haven't practiced in Nigeria now for all over 10 years, but I have colleagues that are practicing. But I know that most teaching hospitals, and in fact, I'm sure general hospitals, have this screening program. I remember that as a young doctor doing intern in Ahmadu Bello University in Zaria, I remember that when I was doing my Osangani posting, there was PAP screening. At that time, it was the spatula that we were using. They were trying to teach us how to do it then. But yeah, there's those services there. We do have, in terms of obs and gynae, I would say, I know certainly for Nigeria, I don't know for other places, in terms of obs and gynae, I can confidently say, maybe not so much the accessibility of service, but in terms of the expertise of the specialists, they're pretty much as good as the specialists that you have here. What will make the difference is the supportive staff that they have. So i.e., in terms of the expertise of an obs and gynae doctor, they probably would be able to do similar stuff like we doctors here. But obviously, when they take the samples, then they have to send to the lab. You don't have to worry about whether the lab people are able to pick it up. But in terms of whether they can do colposcopies and leads, I believe that very much they can. They're doing a lot of minimally assisted, what they call minimally invasive procedure that they do with cameras and stuff now. So a lot of our countries back home do have this service. You just gotta ask for it. Especially teaching hospitals, definitely.
I may add that just so you know, the difference between the developed countries like Canada and Africa is that these services are not rolled out for public consumption in Africa and in most African countries. So individual families and persons have to go and look for them. They are not national programs. They generally, most African countries, they don't have national programs for colorectal cancer screening or PAP screening, the PAP examination for cervical cancer, etc., etc. So they are all present, but they are usually for people who are informed as well as people who have the wherewithal to go for the screening.
Okay. So that's it really. Thanks for listening. If there are more questions, we'll take them. We still got some. I'm not sure when I was supposed to finish the presentation. Let me see. So that's where we are. We are Gateway Family Medical Clinic. You can find us on Hebert Road. If anything you want to sort of ask, you can either post them to Madam Heli. You can find us in the clinic. Like Dr. Raymond was saying, for people on this forum, we'll do walk-ins for you. We'll take you on if you need to, even though panel may be full. But please don't neglect these things. Come and have a chat about them. Okay, we still have I believe we just have a couple of minutes for more questions if people have questions.
Yeah, there's a topic that I think was not covered, and I think it would be nice if we can talk about it.
Okay,
Vaccines and vaccinations.
Oh, okay. Okay, Dr. Asongo, do you want to go for that?
But particularly the COVID one that everybody, we hear all kinds of things and all that. I mean, I've taken both, but everybody is just throwing information out there. So it would be nice to hear from you professionals about it for our people.
Vaccines and vaccinations are a very big topic. Vaccination starts in Canada. In Alberta, vaccination starts from the age of 2 months from birth until about 16 years when the government stops the vaccination program. The early vaccines are much too extensive for me to present in this forum. Suffice to say that those vaccinations are very important, and they generally, I can name those vaccines for you. They include polio vaccine. They include a DPT, that means diphtheria, polio, and what's the other one? DPT, tetanus. Yeah, and then you have the meningococcal vaccine. You have the hepatitis B vaccine. You have the pertussis, and then pertussis is the whooping cough, and then you have chicken pox. Those are the and then you have tuberculosis, obviously, which is the TB vaccine, which is not generally for everybody, but a select type of people. So those are vaccines that are important to prevent against disease in the early stages. And I think by and large, the overwhelming majority of moms or parents have those vaccines because they're educated, and they have educated in the prenatal period and after birth as well by the midwives, and most people get those vaccines, unless of course some people who have their personal beliefs against those vaccines. They decide to, and that's nothing we in Gateway Family Medical Clinic can do anything about. But the one that in terms of vaccination, the one that I would like to actually talk about is hepatitis B and hepatitis C vaccines. Now, these two conditions are very, very predominant amongst Africans, especially in Alberta. We have a lot of people who are carriers of hepatitis B. Now, the thing is that there is no existing, as far as I know, there's no existing vaccination program against hepatitis B in most African countries. So most of us who immigrate to North America come as adults, and the government stops giving the hepatitis B vaccine in secondary school in Canada. After that, after you leave secondary school, you're on your own. You have to go and look, because when you take the vaccine, it lasts for maybe sometimes 5 years, 7 years. Sometimes some people can have the antibodies in their body up to 10 years, and it expires, and then you have to go and do your own vaccination. And it is very important to have hepatitis B vaccine. It is more contagious than HIV. It's far more contagious it's one of the most contagious virus, and is responsible for causing liver cancer and liver cirrhosis, which is damage to liver. So a lot of people go around are perfectly healthy. They don't look, they are not ill with it, but when we screen them for testing for one reason or the other, we find they are carrying the virus. And if they have like intercourse with somebody, or they accidentally exchange body fluid one way or the other with somebody else, then they catch the virus. So also is hepatitis C. Hepatitis C is also present, but it's much less common than hepatitis B. Unfortunately, there is no, currently there's no vaccine against hepatitis C, so it's much more deadly. There is treatment for hepatitis C, which works which doesn't work for everybody, but it was extremely expensive treatment. But there does exist a treatment for hepatitis C. And which the other immunization that people should have is shingles vaccine. There's a shingles vaccine which is available. Most insurance company cover people who are older than 50 years, and the reason is because people who are older than 50 years are much more likely to get shingles. And the reason you need to have prevent against shingles is because it's not just the pain. A lot of people and the rash. A lot of people get chronic pain, which we call post-hepatic neuralgia. So some people get lifelong pain after catching the shingles. So that's why it's important to prevent, have immunization against shingles. You can if you are an adult and you are from Africa, for example, you've never had chickenpox, I would strongly advise that you go and have the vaccine because chickenpox is very deadly in adults. In fact, I lost a colleague in England before I left England about 8 years ago to chickenpox. So it's important to know about chickenpox vaccination as well. Other than that, all the other vaccines that we have, we already talked about them, and as I said, we talked about the HPV vaccine and prevention of cervical cancer. If you remember any of the vaccines, again, the other vaccines are unknown in Africa. For example, the typhoid vaccine is a travel vaccine. If you want to travel, this is important, I think. If you want to travel to Africa, for example, and you want to have your prevention, we in Gateway Family Medical Clinic, we give a low-cost travel vaccination thing, the same thing that you will obtain from a travel clinic, and pay them about $200. I think we charge about $40 or $75. I'm not too sure. And then you get your typhoid vaccine, you get your malaria prevention, you get your we get typhoid. You can even have the yellow fever vaccine on special order, as well as the cholera as well, if you want to have cholera, although that's becoming much less common in Africa than before.
Yeah, thank you, Dr. Asombe. And sorry if this goes off, I'm going to continue on the phone. I think people were interested. That was very informative. Thanks very much. I've seen a question on the chat box about, we've got a listener from Africa. I don't know, this must have been very widely shared. They're asking how much is it going to cost to access the screening services from Africa. I know it's $0, just text us. But no, thanks. The other thing, somebody's raising their hands. I'll let you speak in a minute. But with regards to the COVID vaccine, I know yeah, sorry, my other one just went off there. Okay. So I know there's varied opinions about it, but my personal opinion is if you don't want to deal with the consequences of the COVID, you're worried about whether the skepticism are not unplaced, right? I have taken both vaccines. I encourage people to take it if they feel comfortable with it. And the reason why I say that, obviously I'm biased, being a doctor, I have to tell you to take vaccines. But beyond that, the way I explain to patients is that you can only have that dilemma if you're alive. If you catch COVID and it becomes fatal, then you would wish that you had the vaccine. Okay, so if you become very unwell, then it would not matter whether the vaccine was deadly or not, or maybe whether it was genetically engineered or because you're only alive to have those discussions. If you're not, then and if a lot of people are taking, I mean, you don't go to the bandwagon, follow your mind, but I think that the argument is that, my personal view is that you should take it. We know all the vaccines we have. We have in Canada, we have the AstraZeneca, Moderna, and Pfizer. The Moderna and Pfizer are genetically engineered. They're mRNA vaccines, which is the new one, which is one that's causing a lot of anxiety. The AstraZeneca is your normal sort of vaccine type, in quote, vaccines, because those are the ones that they are, the antigens that trigger antibody responses. So your vaccines normally would be some form of particles that has, that will give the same responses that the disease would give. So it would be that they would either life attenuate, so they'll kill the particles, so that, and then inject into you so that your body can remember it and produce what they call antibodies, so that if you get the actual infection, your body deals with it, or they give you the actual live vaccine, which is the actual agent is injected to you to produce the response, so that your body remembers it later. And then that's what the AstraZeneca does. So that's my personal opinion. But again, there's a lot of diverse opinions. So yeah, if you've not had it, it's free. Nobody's charging for it. It's still all over the place. Over the reason why Jason Kenney is opening things up is because, like we hear, more than, I think 90% have, or 70% have had the first one, and the numbers are going up to 30-40% for the second one. Okay. And then there was something about the vaccine and shingles. Let me look at that question again. What was that again? Is shingles applicable to Africa? Oh yeah. I've seen some really brutal shingles in some African people. Is you get that huge rash, very painful. Yeah. Is the COVID vaccine safe? Yeah, I've said my piece on that. There's several theories, conspiracy. It's the 999 is the number of the beast, is all of that. So. Dr. Ejo, do you have anything to add?
This is excellent. Wow. You guys are mind-blowing.
I just want to add one thing before we go. Just so you are aware, Health Canada advises everybody in Canada to take vitamin D. Vitamin D has a lot of advantages in that have been proven to be effective. It is important in preventing a lot of cancers. It's important in preventing osteoporosis, that is weakening of your bone and fractures. It's important in, it actually works important in preventing dementia when you get older. It's important in, actually right now, even psychiatrists are prescribing vitamin D for depression. So it is extremely important for you to take vitamin. If you are an African living in Canada, you are 100% deficient in vitamin D unless you've been taking vitamin D. You cannot make enough vitamin D by staying in the sun, because when you move to North America, you lose the ability to manufacture vitamin D. So there is not enough sun in Canada for you to make vitamin D. You make vitamin D from the sun. So take your vitamin D. If I usually advise my patients, if you have not been taking vitamin D, go and see your doctor to test for vitamin D before you take it. Because if you start taking it at very low levels and you take a small dose, you will never get normal values in your bloodstream. So take your vitamin D. If it's normal, then you, as an African person living in North America, you should take at least 2 tablets permanently every day for life. That means 2,000 international units of vitamin D.
Thank you, Dr. Asengwe. Mami, sorry, Mami iPhone, I don't know who that is. I think Mami had her hand up before. Do you still want to speak? Mami? The gesture showed that you had your hands up before, but maybe not.
Oh, okay. Yeah, I did. I was just about to ask about the blood pressure. I don't know, low and a high blood pressure. Can you heal like completely from it? And if you are taking the medication, can you at one point of your life stop taking them and just be free from it, like the blood pressure, low or high?
Yeah, so I get that question all the time, and this is my practice. I'm going to offer my colleagues may practice differently, but my practice is what I do is, so just to put it in context, I know a lot of people don't do so. Blood pressure, you get a top number and you get a bottom number when you go and do it. You get a top number that's called the systolic blood pressure, and then you get a bottom number that's the diastolic, right? So we generally want the systolic to be anywhere between 90 might be a bit low, but generally medically you're looking at 100 is more like it, from 100 to at least 135. It's a safe limit, 100 to 135, and the bottom one to be 60 to at least 85 or 90. So high blood pressure is when the top one is more than, well, certainly you can start talking about stage 1 high blood pressure once the bottom one is about 140 consistently is the word, and then once the bottom one is above 90 consistently. So to answer your question, and then the whole idea of taking medication is why blood pressure is important is because of cardiovascular risk. Okay, so risk for heart attack, stroke, and in itself, high blood pressure is no problem, but it's a risk for several other cardiovascular issues. So whether it be blindness, which is more arteries in the eye, or whether it be heart attack, or whether it be stroke. Okay, so going to your question, so when you take the medication, yes, it does help you reduce your blood pressure, but you might be able to come off it only if you do other things. So people think medication is the answer, and in that presentation I was showing you, yes, you take statin, but you also have to do lifestyle changes. Okay, so you have to modify your diet, you have to make sure you're exercising. And if you do that, if you do significant lifestyle changes, I've had patients that have not on my advice, because generally the advice is that it's a maintenance, but they've been able to just stop it and not take it. If you come to me and say, I've had this blood pressure medicine, I just want to do a trial without, and I feel convinced that you're doing significant lifestyle, I would let you do it, and then we'll monitor it together over 3-4 months and see whether your blood pressure is staying normal without taking it. There is some argument that it's not that the medications are only bringing up blood pressure, they are also protecting some of your vital organs. So for example, if you're on A, beta, or amlodipine, whatever you're on, in addition to bringing out your blood pressure by the mechanism that they work, they also have secondary benefits to your heart and to your kidneys. So that might be some of the reason why you want to stay on it, even if it's at a low dose, right? But to answer your question, yes, there are people that have been able to go off it with significant lifestyle changes. Dr. Aswangwe, Dr. Ajayi, I don't know if you want to add something.
Well, I think you've already raised the most important thing, but what I usually tell people in Africa when I go for medical outreach, I always encourage them to be on their blood pressure tablet, even if it's within the normal, because it protects their heart and their kidney. People that doesn't have access to medical services all the time and suddenly stop the blood pressure medication, by the time you see them, they will have had a stroke or a heart attack. So I think if you want to stop your blood pressure medication, try and make sure that you are in regular contact with your family physician. That is, if you have your regular one. But to be on the safe side, even if your blood pressure is normal, keep on maintaining it at a steady dose. That goes a long way to help you. Thank you.
Thank you.
Okay, thank you very much, everybody. That was very enlightening. When you are enjoying the program, then it's moving fast, it's coming to an end. We have come to the end of this program, but I'll just allow Elaine to, I don't see Charles online, but we need to talk about our programs and come to an end with the program. So Elaine, if Charles is not there, I don't see him online. You want to make that presentation. Thank you. And then we can close from there.
Okay, thank you. Thank you everyone for joining today's event. Your presence here has made the event a success, because if the event was organized and people don't come to participate and ask questions, it will not be encouraging. So we want to say to everyone that has connected today, thank you for connecting, and thank you to Drs. Jide, Dr. Ajayi, and Dr. Raymond. We truly appreciate your presence. You're also present in our community, also gives us a lot of encouragement and confidence that we have people that look like us that are, you know, providing this service. And so we truly appreciate it. And just to let everyone know, our association, we have different events that we organize, and we encourage people to attend, because if we do not do this event, we become irrelevant. We just become like, okay, they are people of African descent. They're just there. They will just go to work and, you know, and just stay. But when we organize events like that, we keep putting ourselves out there, that we're a community of people that are not just here to live and work. We participate and we bring value, because this event actually brings value to our community, you know. And, you know, even if we keep working, if we're not healthy, you know, we'll end up losing money, because health is actually wealth. Because if you have so much money, you live in a big house and you're sick, you're not going to be enjoying the life very well, you know. So we truly appreciate these things. And just to let us know, some of the events we'll have in future is that we're planning to have in July a roundtable with the community, you know, as a follow-up from what we had last year, to find out from the school boards, you know, to say what's happening, you know, with regards to bullying and things like that in the school. So in July, we're going to have that community engagement in July. And in August, we're going to have evening in the park stroke our annual general meeting. We hope to have lots of people bring food and for us to share and review our 1 year as a not-for-profit. So we have July, there's going to be something in August, and in September we have Alberta Culture Days. We're going to be representing our community for Alberta Culture Days. Different countries will be represented. And in October we'll have It Takes a Village for grade 7 to 12. And in November, we'll have our fall Valley Village fundraiser. In December, we'll have an end of the year party. All these events, the physical ones, will be dependent on things opening up. And we're hoping that more things will open up to allow us to gather outside. And we encourage everyone, when you hear our event, please participate and join, because our participation is what is making this whole organization a success. And as we always say, we are in it together to make it work, you know. So we say thank you so much. I saw Dr. Jide's hands up. Dr. Jide, did you have something to add?
No, I was just clapping.
Oh, okay, thank you, sir. So yes, so we say thank you, every member of the community. You're the one making the community big. You're the one making the community work. When we organize events, when you come out, when you show up, you know, we make it work. And when you see it online, please like and share. Let other people see what we're doing, so that our community is more visible. We want to be visible in our community. The more we're visible, it's difficult for somebody to put their hands inside our eyes when we're visible. So on behalf of the board, members of the board are here. We say again, thank you so much. Thank you, Gateway Medical, for giving your time. We say thank you so much. We appreciate all of you, your time. We know you all worked today, just so people know they worked today. They were at work, you know, and they still came and volunteered their time to do this. And please, they are very available. You know, sometimes we call them at odd hours to ask them. They are very, very available to help us. And we're so blessed to have them. So thank you so much. On behalf of the board, we say thank you.
You're welcome. Thank you.
Thank you very much for the invite.
Okay, so I know there was one part we didn't talk about at all. The other medical services like massage, orthopedics, osteopath, chiropractor. I know we always give letters if people want to use those services. We want to encourage people to check your medical plan, know what your medical plan covers. Some of us have a massage plan that we don't use. We have physiotherapy that we don't use. So I think it's something that we wanted to say, that people should know what your plan covers and make use of it. You know, it's not doesn't mean you're enjoying too much if you go for a massage. It helps you to relax. Take advantage of it.
True. Yeah.
Yes.
All right then.
So we'll call it today now. Thank you very much, everyone. And you're free to connect with any of the doctors anytime.
Thank you. Bye-bye.
Thank you. Bye.
Have a good weekend.
Bye.
Enjoy the sunshine. God bless everyone.
Yeah, bye-bye.
Bye.